just cut to the chase here. Why are we not having more people like you or public health prevention focused people out there? What are the barriers to the more?
The quick answer is that the incentives to do work in health are aligned more with the flow than they are with creating the trickle. It is set up in a way where treating things downstream is more lucrative for some who have a tremendous amount of ability to organize themselves in a way that the funds that support the health of our nation end up there rather than up here. The tyranny of the urgent is something that drives some of what happens. So we think about a pandemic. During the pandemic, there was some ability to move resources to where the urgent was indicating those resources needed to go.
That's not always the case.
I feel like it's not always the case that there's enough resources, but there's at least oh my gosh, we need to figure this out. Sometimes timing gets in the way. Sometimes the ability to move those dollars quickly gets in the way. Sometimes political will gets in the way.
We spend a tremendous amount of time collecting the dots. We need to spend just as much time in connecting those dots. And that's what Public Health Connect is all about. My name is Dr. Umair Shah. I'm the Secretary of Health for the great state of Washington. This is Public Health Connect.
I cannot say enough about our guest today. This is Dr. Eduardo Sanchez, who's been not just a health leader, a mentor. You've got me through so many emergencies and other issues, but also a friend. You are the Chief Medical Officer for Prevention at the American Heart Association. You are also the former commissioner for the Texas, at that time, Texas Department of Health, that became Texas Department of State Health Services, the health commissioner for the entire state of Texas, and you have gone through so many different trials and tribulations when it comes to health and policy and all sorts of things in between. So, Eduardo, welcome to Public Health Connects.
Thank you for having me. I think most of what you said is true.
I don't want to know which isn't, right? You're up to so many amazing things at American Heart Association. Just talk a little bit about you, your work, your team, what you all are up to.
Sure. I get to do a lot of really great stuff at the American Heart Association. I'm going to start with a mission statement, and I share it because I don't know any other mission statements of any organization I've ever led or worked in. It's just an awesome mission statement to be a relentless force for a world of longer, healthier lives. And the amazing thing about that mission statement is that it is so much about opportunity. It is so much about somebody coming and asking me to have a chat about you name it. The answer is always yes, because if the possibility is for longer, healthier lives, let's talk. And so in my job as Chief Medical Officer for Prevention, I get to be the voice, the perspective, the consultant, the so-called expert, the person with real-world experience of all things, I would say, upstream from specialists, cardiologists and neurologists in particular. We're the American Heart Association, American Stroke Association. I was involved with the American Heart Association as a volunteer since the late 1990s. Wow. In fact, one of my children attended more board meetings than anybody but me the year that I was president of AHA in Austin, Texas, and they were made an honorary board member that year. So I've been with AHA in some form or fashion for quite a long time. I've been working for the American Heart Association for 11 years. I say that because I am a family physician by training and a public health physician by training.
Yeah.
And when I was president of AHA, I used to say, somewhat tongue-in-cheek, primary care docs do more cardiology than cardiologists. And in the name of prevention, and we are prevention-minded people, the degree to which you get things taken care of upstream, whether that's vaccines or screening for depression or making sure that someone's blood pressure is under control or is healthy and not in need of control, all of those things are ways to prevent downstream bad things from happening. So when primary care is able to do the cardiology part of it, the cardiovascular health part of it well, the AHA is addressing its mission to be a relentless force for longer, healthier lives. And if you take that further upstream, which I get to at least talk about and support some of the work that we do that's upstream from primary care, work that happens in community settings, work that happens in workplace settings, work that happens in school settings, work that can happen in partnership with local, state, and federal health departments and other agencies. That's the degree to which the downstream consequences of what didn't get addressed are addressed and taken care of. So I get to do all of that stuff in this job. So I kind of love it.
Yeah. So, okay, so lots to unpack here. Relentless force, right? That this pursuit. I love this relentless piece because you said, how do we get to yes? I mean, there's that piece of this. Then there's this notion of what are we doing to get people to understand the importance of prevention. This upstream piece, right? When so much of our work is in downstream. Unpack that.
Sure.
What relentless reminds me of sort of effectiveness, efficiency, strength, and coming to the table every single day, even if it's hard.
Yeah. So
and coming back again.
Absolutely.
Yeah.
Tenacity and persistence are the way I might put it. I mean, just you don't stop because the possibility of something better always exists until you get to that better, and then you push for even better. So it is, in my mind, doing all things. So let's be clear. Downstream is there's always going to be a downstream.
There has to be, yeah.
One would hope it's just a trickle, but you still have to address what comes downstream. So in another role that I had in my life was the chief medical officer for Blue Cross Blue Shield of Texas. And at that time, I used to say the degree to which we can do things 90% of the time when we are rendering decisions about things like treatment, the degree to which we can know with confidence that 90% of the time that guideline works. That allows us that 10% of the time to have some flexibility around what we do. The other thing I would say is that when you have limited resources to do things called improving the health of all people in the United States of America and all people globally, if you take an international frame, then the degree to which you can do more up here, which in general either is more cost effective or is more health effective. Health effective meaning you spent the same amount of money, but you achieved a health outcome that would have cost the same, but but would have cost you the same without the health impact that you had. The degree to which you can do
the return on investment,
and return on investment in every way that one could think about it.
Not just financially.
Not just financial, and not just to those who are, too often return on investment is about, well, what does the health system gain from this, as opposed to what's the return on investment for a patient and their family? We ought to be thinking about return on investment in a broader way. And I think that at AHA, being a relentless force allows us to even, to put those sorts of things on the table and have those conversations. But getting back to the question at hand, the degree to which one can do those things well upstream, whether it's at a population level, a primary care level, even at a initial specialty level, those things that don't have a path of prevention, there's some things that happen that you can't prevent. Or that because we live in a complicated society and in complicated worlds, we didn't leverage all those opportunities that we could. we still want to have the capacity and the resources to address things downstream. So the American Heart Association is about writing the clinical guidelines that people who see patients put to use to translate the science into the way that one should practice medicine. We believe there's one more step from the what, blood pressure at below 130/80, into the how. So how does one do that in a clinical care setting with these sorts of patients? Or how does one do that in a health system that is really, really complicated? So translating science to guidance, and then translating that guidance into programs or implementation, et cetera, and so on.
So you talked about this downstream, trying to keep it as little
A trickle rather than a flow.
There you go. Yet we know that if somebody is having a heart attack, you still want to have the ability to have that person access care.
We want that person to, I think something's going on. Let me call 911.
That's right.
And everything that happens from that point forward,
we want that
we want it to be done in a quality way. So I will say to you that one of our mantras is access to high quality care. So access would be everybody having insurance, or since insurance is the pathway to care. But once you have that access, everybody having access to the highest quality care available for every single person.
So just because you have insurance doesn't mean you automatically are going to be healthier. We have to then drive people to be able to utilize or work on their health.
Well, and depending on the state that one lives in, just having an insurance card doesn't even mean you have the ability to access the care when you need it. Yeah. So it may take you several weeks to get a primary care visit. And then once you have it, you may not be getting the highest quality care. So we would like to be in the conversation at every step of that, that you have the health insurance access, that access means there's availability of care when you need it, and that care is of the highest quality. And I would say to you, we apply that sensibility about public health as well. So I'm a public health practitioner, just like you are.
Yeah.
And when I was a state health commissioner of the Texas Department of Health first, and then the Texas Department of State Health Services, I practiced evidence-based public health. Everything I did was based on a body of science, a body of knowledge, and sometimes, maybe like you, I had the privilege of having really smart people who could interpret those really hard articles, because my brain is not sophisticated enough to understand all that science. So I had people that I trusted who interpreted that science for me, and we put that science into work in the way we did our programs.
So it's the practice piece. But so N of 2 in terms of the science. So thank you for that. So there's 2 of us. I'm glad there are other people around that are smarter and can pull that together.
Hey,
it's all good. It all works.
Team-based care is so important, and it's applicable in so many places beyond the clinical care setting. There is no way that you can accomplish what you accomplish, and that I could have accomplished what people say I accomplished, which was accomplished by a group of people that I was a part of and was the designated lead of. Yeah. But it was a team of people who had different skills, different perspectives, different experiences, all of which led to a much better product than one person driving it all straight from just their brain and just their own experience.
So that first conversation we were having about wanting to make sure that if somebody has that heart attack or has that acute issue, that care is there. But there are other piece of this is the upstream prevention piece.
Yep.
Talk a little bit as a family physician,
yep,
from training and all the years that you saw patients. There's this responsibility and real opportunity for us to impact the future generation of prevention from a prevention lens.
Yep.
So talk about, what does that mean to you?
Sure.
How does that vibe with your soul?
So I consider myself fortunate in that in my life I've had experiences and relationships with people that broadened my my scope of vision. My peripheral view was expanded. And that peripheral view started in medical school with kind of the focus on the individual patient. The exposure to people and then me beginning to question, is it enough to do things one-to-one? Is there a way to do one-to-many and amplify the knowledge and get even more potentially positive outcomes? I began to understand, because I went to a family medicine residency program where a couple of things that were very important to me I was able to experience. One is that I chose a family residency program with a very high percentage of Latino Hispanic faculty. It was really important to me to know what I could bring to that clinical care setting experience. We all bring individual skills and experiences whose value together could result in a different care experience on the part of the patient. And one can leverage that for the positive. So a real easy example is Spanish-speaking patient might benefit from having a Spanish-speaking physician, and might benefit from a physician who has family who extends all parts of the socioeconomic continuum. So I had cousins and uncles and aunts who lived okay, and I had some who lived not so okay, and yet it was all okay. So not okay using the objective measures that sometimes we use to measure what the continuum is. I'll just leave it there. But I also had the great privilege of working in a family medicine residency program where a social worker was a key member of my team, of my learning experience, more importantly, let me put it that way, and that I began to appreciate how important it was to know the context of a person's life. So I'm saying all of that because, yes, there is the gleanings that came from being a clinician who had all this knowledge that he learned in a medical school. Yeah. But then there was the learnings of how to continue learning and getting input to how you think that helps me be a better physician clinician, a better public health physician, a better public health practitioner who understands that while I know that there are 8 things that when you do them well, you are going to achieve optimal cardiovascular health. Sure. So I'll do a plug for Life's Essential 8, American Heart Association's construct for cardiovascular health. That's healthy eating, physical activity, not smoking, plenty of sleep, and having normal or controlled weight, blood pressure, cholesterol, and glucose. And you can go look at the evidence base. If you're good on those 8, your cardiovascular health is going to be darn good. That's a technical term, and it's going to be darn good for life. So if you reach 50 and you're really good on those things, then you're going to reach 80 and 90 with a low burden of chronic disease. You're not going to contribute to the flow. You will have helped it become a trickle, and in turn, Life's Essential 8 and cardiovascular health is associated with other collateral benefits. Less likely to have diabetes. You're less likely to have depressive episodes. If you are somebody who's prone to depression, they're likely to last shorter amounts of time and be less severe. Cognitive decline is arrested, delayed, or prevented. So Life's Essential 8 is a nice starting point for a clinician trying to figure out how do we get to Life's Essential 8 for you. Some of it is, here's what you can do, but part of it is understanding the context in which someone lives their life. So an example would be, Ms. Gonzalez would say to me, Dr. Sanchez, I want to walk, but at 5 o'clock in my neighborhood, it just doesn't feel very safe.
Yeah.
And I would say to the Mrs. Gonzalez's, walk at 7 o'clock in the morning. It's a little more quiet. People who are maybe not doing the healthiest things are sleeping it off, and you will feel like you can control that environment.
But still do it. So it wasn't don't do it, and it's let's find the way to make that happen.
Now, the good news is we live in a society now that has figured out that there is a role for some folks who can extend the walls of primary care into communities. Community health workers can be the folks who maybe go to Miss Gonzalez's house, go to Miss Gonzalez's neighborhood, and can provide even more guidance on the one hand and insight for the clinical care team on the other hand. So I don't know if that was the answer that you were looking for, but it's the answer I'm giving. So let's just go with that.
It actually is, but I will tell you a couple things. One is that I call that not just the science of medicine, and we talk about the art of medicine, not just the science of public health, the art of public health. So I think there's a lot to unpack there. Let me ask you this. Just cut to the chase here. Why are we not having more people like you or public health prevention focused people out there? If we say that we've got to do something because we're going in the not so good direction with life expectancy or healthier lives or all the other measures and metrics that are out there, right? We're not sleeping enough. We're not doing. Why are there not more? What are the barriers to the more, getting more people to and I'm not talking about more of the 300 plus million Americans.
Yeah.
That's another question.
Yeah.
But I'm talking about the actual practitioner. How do we get more of like the prevention minded people to actually pay attention or to be prevention minded if they're in that downstream healthcare delivery world? And quick answer on this, because I got two more questions for you. Yeah.
I mean, I think the quick answer is that the incentives to do work in health are aligned more with the flow than they are with creating the trickle. It is set up in a way where treating things downstream is more lucrative for some who have a tremendous amount of ability to organize themselves in a way that the funds that support the health of our nation end up there rather than up here. The tyranny of the urgent is something that drives some of what happens. So we think about a pandemic. During the pandemic, there was some ability to move resources to where the urgent was indicating those resources needed to go. I feel like it's not always the case that there's enough resources, but there's at least oh my gosh, we need to figure this out. Sometimes timing gets in the way. Sometimes the ability to move those dollars quickly gets in the way. Sometimes political will gets in the way. Over here, the system is set up as a default to be the place where there is a continual ability to support the care of somebody who has a myocardial infarction, a heart attack, or the person who has a stroke. We will take care of that. This work is hard work. It's not always rewarded in ways that are commensurate with the impact that work has. And I would say those are a few of the challenges that get in the way of getting it done.
And even in training, so we're more exposed to taking care of the patient with the heart attack in our, if you're in medical school residency, you know the steps to be a cardiologist.
That's
so
right.
It's in your face every single day. You know how to do it. But how many are in that prevention or public health? It's not
enough. We are trained to deal with the flow, even though there's a spigot that could be turned to close to off. There's always going to be some leakage, as we talked about before, if we're going to continue using the plumbing analogy. But we don't even talk about how to close the spigot a little bit, and we don't put the training and we don't put the resources in the place that takes things further upstream.
Wish we had more time. This is fantastic. Let me ask you this question, and then I'll close with one last one.
Okay.
The question is about hope. So we've talked about all the impediments and all the barriers. What gives you hope as you look into next year? What gives you that all these impediments, all these incentives, all these to keep the system or the pieces the same or similar. What gives you hope?
So 3 things. One, from 1900 to the year 2000, life expectancy in the United States increased by 30 years. Most of that was due to things that are public health and population focus. I have the confidence that there's still the ability to move the needle on a population basis.
Okay.
Secondly, I think that the science that's out there that tells us what could be done brings me confidence that the other thought that I have is that when you put smart people in a room, they will eventually come up with the right ways to approach a problem. So what we need to continue doing, as public health people know how to do, is bringing people into the room, being the convener who can help, point to a world of longer, healthier lives, and then pose the challenge of how do we get to that place. And the third that I'll mention is the quote that I've been using for a few years now, that I'm not an optimist, I'm a very serious possibilist. And so the possibilities are not only endless, but they are achievable. And we don't need necessarily, I'm not saying we shouldn't seek new ideas or seek new science. I would never say that. It's that we have enough to work with that we could advance the cause in a very, very significant way. I would be remiss if I didn't mention one thing.
Sure.
There's a couple of words I didn't say at all. And I just want to be clear to anybody who's watching Eduardo Sanchez that they loom in my brain all the time. And that is achieving health equity and eliminating health disparities. Every single thing I said has to be done with the thought that achieving health equity, eliminating health disparities is the foundation to all that we talked about. That flow has to be in an equitable, the reducing the flow in an equitable way and reducing any disparities of the hot water, medium water, yellow water, green water that are all adding to it. Equity, elimination of disparities. I think it's really important to say that.
I love that. I love that. What a way to close. Okay, let me grab this. This is our Be Well WA, the UL Washington initiative. It's our apple, stress apple, so don't eat this. But I will say this is our health and wellness initiative. It actually very much aligns with what you talked about with the American Heart Association: movement, nourishment, emotional well-being, social connection. And what we've been saying to 8 million Washington residents is find your apple. Okay. What's your apple? So people say, well, my apple's jazz, my apple's walking the dog, whatever that is. As I give this apple to you, one Dr. Eduardo Sanchez, I ask you, what is your apple, sir?
My apple is being good with me and those around me. And I say that because if you're not good for yourself and to yourself, I don't think you're optimizing the ability to be good with, for, and in the service of others.
I love that. I love that. Here's the apple. Eduardo, thank you so much.
Thank you for having me.
Great time. This has been fun.
Thank you for having me.
I love this. Thanks so much.